Hello and welcome to another episode of Taking Control of Cancer, the podcast brought to you by the North East London Cancer Alliance. I'm Steve Bland, and in each episode of this podcast we try and give you a little bit of guidance, a bit of a how-to guide to help you take control of your own cancer story. We know that not all cancers are curable, not all cancers are treatable, but there are things that we can all do to support ourselves and our loved ones. And that's what we try and do in this podcast, give you some tangible, useful advice. In this episode, we're talking about bringing in the experts for a cancer diagnosis, and it's all about looking behind the scenes at the work that goes on into a diagnosis and discussing a treatment plan. And I really want to explore MDTs and streamlining we're going to talk about as well. And we're doing that with Quinney, who is the Programme Manager for Diagnosis and Treatment here at the North East London Cancer Alliance. Hello, Ellen.
Hi.
And also Ben Lamb, who is the MDT Clinical Lead for the North East London Cancer Alliance. Hello, Ben.
Hello.
Yeah, go on then, Ben. Just let's explain. What is the M, the D and the T?
Yeah, sorry for interrupting your flow earlier.
No, that's fine.
So M is multidisciplinary,
yeah,
meaning not just surgeons, not just oncologists, not just nurses, but a wide range of healthcare professionals. That's the D as well.
Yeah.
And then the T is team, so we work collaboratively together.
Let's sort of take it back a little bit then. So I know the process of going to the GP, you know, them saying there's something that needs investigating, you go onto a hospital, you might have a biopsy, a CT scan, MRI, whatever it might be to diagnose that somebody has cancer. And then we go home and feel like, you know, your world has fallen apart. Those notes and the person that you've seen go off, and, you know, all the wheels all start turning in terms of, you know, what the treatment's going to look like and what the next few months are going to look like. What happens on your side of the fence when we've left the office and you guys crack on and try and work out, you know, what happens next for that patient?
Yeah, so patients who are either suspected of having cancer or who have had cancer confirmed by tests would be referred to the MDT meeting. And that's a kind of usually electronic or paper-based. It's coordinated by an MDT coordinator who's an administrator who puts together a list of patients who need their cases reviewed, their tests reviewed, and then usually once a week the team meet together and go through a series of patients to review their tests, review their background, what the problem is, try and put together an understanding of the diagnosis, and then consider what are the options going forward, what are the other tests that people need, or what treatment options are recommended, and then fixing a follow-up appointment to discuss that with the patient.
So Ellen, I have this image of like I don't know why it's a square room, but there's seats around the outside, and everyone's saying, I've got this case, and this person's got this, and this has happened to them. What do you think? And everyone sort of pipes up. What's the reality of an MDT, or is it exactly like that?
I think now a lot of MDTs are happening virtually, or at least a mix of in the room and virtually.
Was that a COVID thing?
Yeah, absolutely. And because we've got experts that might be sitting in different places geographically, having that hybrid and people able to join remotely means that we can get more of the right people in the room. But yes, each case is presented, talked about, and then those group of experts kind of decide the best way forward in terms of treatment options.
Is it just a load of consultants all arguing? Or who's in that room, or who's in the virtual room?
So it's made up of, so for any that they're kind of arranged around particular types of specialty or cancer types. So I sit in a urology cancer MDT meeting where we'll talk about kidney, prostate, bladder, testicle, penis cancer. So there'll be urologists there. So and that would be colorectal surgeons for a colorectal MDT, for example. You'll also have oncologists who are the cancer specialists, specialising in chemotherapy, radiotherapy, other treatments. You'll have the people you need for understanding and interpreting the tests, so radiologists to look at scans and x-rays, pathologists to look at biopsy samples, tissue samples. Then you also need other people like specialist nurses who are very good at keeping it patient-centred and thinking about the patient as a whole and bringing things together. And then sometimes there might be others like radiographers, physicians, other people.
So how many people in total is an average MDT?
The ones I sit in at any one time, it may be 15 to 20, 25 people.
Right. And how many cases would you cover in one kind of sitting?
So that's variable. So some MDT meetings may discuss 15 cases, some it may be over 100. And so some meetings go on for 4 or 5 hours, some maybe an hour.
I'm fascinated, Alan, because, well, actually both of you, I guess, we've talked in other podcasts about, things like seeking second opinions. We know that cancer treatment isn't black and white. There isn't one path for a treatment plan. There's different options. My experience, my wife was told that she needed a mastectomy, and then another guy said, well, no, she doesn't. It was, lumpectomy would be fine, and some more treatment. How on earth is a consensus reached among people who, not to cast aspersions, but they're quite, a lot of these people are fairly confident of their own opinion. So how do you reach a consensus on a tricky case? Both of you, I guess, I would have a take.
A lot of the time, or some of the time when people get cancer diagnoses, there might be an inclination to say, I need a second opinion. I need to make sure this devastating news that you're telling me is actually correct because it's life-changing for me. And I think it's important to get across to people who are going through that process that the NHS and cancer care has built into it various kind of checks and balances and safety mechanisms. So we have established MDT meetings as kind of best practice to challenge ourselves, challenge each other, to make sure that we stay at the edge, at the cutting edge of kind of best practice, so that we're giving research evidence-based decisions, that we're there, that we've created a safe meeting space to challenge one another. Ben and I do some work, or running some work within our programme around education, around breaking down kind of hierarchies and cultures that might exist within those meetings, so we don't just default to the surgeon who might have the loudest voice, but we're actually kind of building in ways so that people's views are equally represented, as well as the patient views, and the nurses who might have already met the patients and had those kind of holistic conversations with them.
I get that, but how do you get to a consensus? At the end of a meeting or a session, like how is a plan formed when I imagine there's a lot of different opinions quite often on a tricky case?
So most people are very well behaved and work collaboratively. There'll be someone who will have read up on the case details, so they're familiar with what's been going on. We'll give a short presentation on that. The radiologist is often then invited to take the group through the scans, try and interpret and explain them. Same with any biopsy results with the histopathologist. And then it often falls to the chairperson to say, bring in people's opinions. And I think one of the benefits of MDT working is that it does actually improve consistency of treatment recommendations. And if you look at some of the science research into it, people are more likely to get treatment and management which is in accordance with evidence-based guidelines when their case is reviewed by an MDT meeting than if it is just a single person.
Yeah.
So that's some of the reason for doing it.
And obviously in that room, be it virtual or in person, there's obviously so much knowledge and talent and information in that room. I'm not trying to kind of paint it as a negative atmosphere. I'm genuinely interested in how. I mean, who has the final say? I'm sure not all cases are. There are difficult cases and easier cases, aren't there? Who has the final say? Is there is someone say, well, I've heard all your opinions. I'm going to ignore you. I'm going to go with this.
So most of the time, most people agree.
Yeah.
Because there is a clear consensus or guideline, and people think that's the right thing to do. There are cases which are complex by their nature, and there may be different options, and some people may favour one option over another. I think the key thing is that is recorded clearly, so that whoever is seeing the patient next in the clinic can explain to them the rationale for the recommendation. And it may be that you have to be honest and say, look, this is complex. There are these two options. We don't know which is best. These are the pros and cons.
Well, don't say that to a
parent. You have to be honest.
As a patient, I really hated it.
Point as well, though, that it's a recommendation.
Yeah.
It's not binary. We're not saying you absolutely have to do this.
Yeah.
Based on the information and based on our expert opinion,
Yeah.
our recommendation would be this. There are pros and cons to that option. There are pros and cons to the other option, but this on balance would be what we recommend.
It's tricky, isn't it? Because we talk a lot about the benefits of being a really powerful advocate for yourself, and to understand your own case and understand your treatment. And I guess the flip side to that is possibly like knowing too much. And I've kind of been, so my wife died about 6 years ago. Actually, when she had been treated, I didn't really want to know. I just wanted you guys to tell us what to do. I didn't want choice. I didn't want any choice. You guys are the guys with treatment, with experience. You've been to medical school. You guys have the conversation and you tell us what to do. We've sort of talked a little bit about the benefit to patient. Obviously, it's you get 20 brains rather than just one. But what are the benefits to patients of the MDT process?
I think, and just going back to your earlier point, I think it's important to acknowledge that that's not the majority of the patients. The majority of the patients aren't contentious, and it's not a kind of subjective, almost sort of jury-esque scenario. There is more often than not a kind of clear ideal recommendation or treatment option for that patient. So it's rarer that it's kind of as debatable. Other benefits, so I think you've got the ability to consider things more holistically. So we're not just looking at what's going to cure that patient of cancer, although that's obviously important, but we're also looking at what's going to have impact on their other aspects, their other quality of life. What might their life expectancy be if we do or don't treat the cancer? Is it worth putting them through sort of a undertaking of surgery or chemotherapy, which is not without consequence? Is that worth it? So it's kind of a holistic appraisal of options.
Those are the ones I can understand the options a bit more when you're sort of balancing up the risk and reward and the quality of life and that kind of thing. You sort of touched on it a little bit already. What are the what work is the Alliance doing to sort of, in fact, I'm going to ask about streamlining, because I wanted to know all about streamlining.
So Ben and I are running a MDT improvement programme through the Cancer Alliance. So we're looking at a few different areas within that. So training and education, so making sure the people in that room at that MDT meeting have got the right skills that they need to do their roles within that meeting as best as possible. And those are kind of soft skills as well, so leadership skills and communication skills. One of the other things we're looking at is streamlining, so introduction of predetermined, so what we would call protocolized outcomes, so where you have patients, those non-complex, as we would call them, patients, or straightforward patients that would have an obvious treatment indication, that we can move those out of a full MDT meeting discussion, which has a lot of kind of resource implications, the meetings themselves, and kind of have a predetermined treatment option based on best practice. It frees up a lot of capacity within those meetings, which the demand is growing and growing based on the amount of people with sort of instance of cancer increasing.
Yeah, because I imagine, I'm going back sort of 10, 15 years, maybe before you were able to do virtual meetings as well, it might have been a much longer process.
Yeah, I think the meeting itself can become a bottleneck if you think it's once a week, but you've got patients coming in every day, and they need to know just as much. They need to know they haven't got cancer as those that have.
Yeah.
And so the MDT meeting once a week, full of patients, perhaps we can't discuss them all, they have to be deferred to the next week, you know, that just introduces delays. So where people's case is straightforward, we know what the right management is, that can be decided outside the meeting. The patient can be told that they're clear or given the diagnosis and moved on to the next steps. And then we can focus on the ones you've alluded to, where perhaps it's more complex, it's more nuanced, it really needs those people to put their heads together, and we can give them the time and the resource to actually making the right recommendations.
So would all patients be discussed at an MDT before the streamlining process came in?
Yeah, so until NHS
even the
England,
even the ones you might consider quite straightforward.
Yeah. And the UK is unique in that, and I think it has been a strength that all patients with suspected or diagnosed cancer should be discussed at an MDT meeting. That's great, except the numbers are going up and up and up. And if you look at other countries, the US, Germany, other developed healthcare systems, they tend to only take the complex cases to their tumour boards. The ones that are straightforward, they'll just get on and manage them. And I think we've strayed slightly from that, maybe a better approach, but that's what streamlining is hopefully going to take us back towards.
Presumably, you can still have informal conversations if you're looking at a case and you're like, oh, you're not quite sure. You can ask someone who's maybe seen a case like that before. You can still have these informal conversations.
Yeah, the streamlining is really just for the most straightforward cases.
Yeah.
So if there's any doubt, the safe thing is discuss it in the meeting with your colleagues, put your heads together, work out what the best thing is. So we're starting very simple, we're starting safe, we're building in safety checks so we can check the process is working, and making sure it's working well for patients and for their teams as well.
So how has technology changed it? And we talked about it a little bit. Post-COVID virtual meetings, has it sure changed the process at all?
So I think yes, definitely. And it used to be face-to-face. People would travel into the hospital, we'd be sitting together. That's very nice from a kind of human perspective, sitting in with your colleagues discussing cases. But it does mean people, perhaps they can't get there every week, perhaps they're meant to be in another place, there's travel time and other things. So actually being able to have the choice of being in the meeting or connecting via Teams, Skype, Zoom, other systems, which are, have really developed over the last 5 years, means you can call on people from, miles away, the other side of the country, to come and give their opinion, which may make a big difference. Does
that happen? Like, do you sit there and you say, well, there's a guy who, in a different part of the country, in Manchester, who is a particular expert in this, get him into the MDT, whereas in the past, would have been just the people in that hospital?
So what we normally do is we cases that are particularly complex or require a certain opinion, we would then refer that case to the expert MDT in whichever part of the country it is.
Right, okay.
And then one of our team would log in, join that discussion, and be able to participate in that.
So it sounds like technology, Alan, has actually really been of benefit to the patient, ability to get more expertise on again those trickier cases perhaps.
Yeah, absolutely. As Ben said, there's a benefit to having people physically in a room together in terms of communication. I think communication in person and virtually is very different, but I think there's been huge benefits to having meetings in a hybrid virtual format. I think we've still got some way to go in terms of how we could use technology. So Ben and I are looking at sort of various software platforms that might be able to support some of the tracking and logging of these decisions and outcoming. So at the moment, that's quite a manual process for the MDT coordinators that sit in that meeting, but we're hoping that we might be able to kind of automate some of that and have that supported by technology a bit better. I think it's hopefully reassuring to patients to know that once they kind of go into that system and onto that cancer pathway or potential cancer pathway, that there are people whose job it is to track them along that process, so they don't get referred into the ether and sort of hope they pass along that pathway and out the other end. There are people who manually step or manually track every step of that journey for them and with them. But we're hoping that we might be able to do some of that sort of supported with more technology to remove some of that manual aspect to it.
Do they get recorded? So if I as a patient wanted to listen back to an MDT regarding my case, could I?
I think that would be tricky because we're discussing so many cases and it's within one recording. It could be infringement of other people's privacy.
Yeah, if you just had that little section. I don't know if anybody would want to, but I just wonder, like, with more and more patients it feels to me anyway, like they're wanting to know more about their cases.
Yeah, we've done some work with there's a team in Germany who have done some research inviting patients actually into the meeting.
Yeah.
And for them to participate in that meeting. And we've done some research ourselves with patients, asking their views, seeing what they think of this whole process. And I think, as Ellen said, patients find it reassuring in general that they've got this team looking after them. They have got the second and the third and the fourth opinion.
If that patient was in the room when you were discussing them, do you think it would change the way you discussed them?
I think go on.
I was going to say, I think yes, because we're guilty of using a lot of jargon.
Yeah.
So yes, it would, by the nature of kind of the language that we use. Would it change the outcome? I don't think so.
Would it change how frank you could discuss that? How honestly you could discuss that patient?
I think people are very professional, and although the patient's not there, we know this is about patients. I think people keep that in their mind, and I think people approach it generally with a level of humanity. So I don't think it's like people would stop being rude to each other.
Not saying that people are rude to each other, but I wonder if you can have, there's a level of information that a patient wants or needs that's probably lower than the level that you guys would discuss it on, in terms of maybe outcomes or a prognosis that maybe you'd only share with a patient as and when they asked or something. I wonder if it would change the way that how honest you could be about a patient.
And I think it's not a one size fits all, is it? Some people want honest and frank, and some people don't. And I think it's like you said earlier about, I didn't want I just wanted somebody to tell me what to do. Some people want all of the information and they want to go away and think about it and sort of give a lot of consideration and thought and research themselves. Some people just want you to tell them what to do. You're the expert, I trust you, just take this burden off me, kind of thing. So I think in the NHS we're a huge organisation, and we sometimes, we need to be careful not to fall into the trap of one size fits all, because that's easier from a delivery method, but that's not what's right for individuals. And I think it's about remembering, when we're talking about people individually, what they want and need.
You talked a little earlier about the technology, obviously the conference calls and Teams and Zoom and so on. Do you think technology has got more it can do with the MDT process? Is there going to be more improvements using technology?
We've been doing some work with companies who have developed AI solutions to help support decision making, help extract the relevant information from a patient's medical records more quickly than and efficiently than a person might do, and then also consider the latest evidence around the world from medical research, which trials might be available, and bring that into the decision-making process. And I think that's something that will give a lot of benefit going forward. I think at the moment, the human touch, if you like, the human perspective is important, but I think it could be complemented by using AI and other technology to make sure we've got all the resource we need to make the best decisions.
And we'll come on to AI, I'm sure, in future episodes. It's kind of a discussion in of itself, isn't it? But the trust thing for patients is a big thing with AI too, isn't it? If you said your case was discussed by, some AI system, as a patient, would you be confident that?
But I think that's heavily based on the assumption that humans don't ever make mistakes, isn't it?
Well, yeah.
I think everybody's got a nervousness around AI because it makes a mistake 0.001% of the time, but actually humans make mistakes too, and I think probably the AI is less likely to make a mistake than a human, but that's a difficult kind of a difficult message to get across or to put across to the public.
You can, well, talking from myself, you can forgive a human mistake, I think, a bit easier than you could forgive a technology mistake. Yeah. I think I was always of the opinion, when Rachel was going through her treatment, she was really keen on seeking second opinions and, almost wanting accountability for decisions, and I wasn't like that at all. I tended to accept the decisions a lot more, and understand that there's 20 people in a room that have come to that decision, and I think that's where the patient should get their reassurance from, isn't it? That there's loads of brains in that room, loads of training, loads of experience. Chances are your case has been seen before in that room by somebody, and that's where the reassurance should come from.
Yeah, but I think that we've got a way to go to making sure that every patient discussed in those meetings gets the same quality, that people aren't getting tired towards the end of the meeting because there's too much work.
Yeah.
That we safely, perhaps decide on, cases that are more straightforward, and we can focus that resource on complex cases.
Yeah.
Where people need the bringing together of the different specialists.
So is that a real balance in that? If you have a busy meeting with lots of cases to discuss, you don't want to kick things on to the next week. You want to get as many done as possible, but you have to balance that against you've been sat there for hours, and everyone's getting tired. How do you balance that? Yeah,
it's tricky. One of the people we've been working with, Tiana Sukup, she's a implementation scientist at Imperial. She did her PhD in MDT meetings in cancer care, and she found you get quite a significant improvement in the decision making, the sharing of information and communication, if you do things like have a small break in the middle of the meeting, where someone can have a cup of tea and a biscuit, take 2 minutes off, and rather than things taking longer, it actually regenerates people, refreshes them, and the quality can get to a high level.
Makes them far more efficient.
Yeah.
So where will we be in 5 or 10 years? Do you think people will still be sitting in a room discussing patients in the same way, or even a couple of years' time? How do you think the MDT process will be different?
I was thinking when we were talking earlier, and I wonder if we'll get to a point where we have a AI generated recommendation prior to the MDT meeting. So AI's been through notes, evidence-based research, and kind of this is the recommendation that we then sense check within the meeting, but not sure I could put a number of years on that.
I think better technology, both, like Ellen was saying, in doing some of the manual tasks that the workforce of the NHS currently have to do, that could be better done by, technology, freeing them up to do things that require humans. I think that would make a big difference. And then helping decision making using AI to get the right information, the latest data, the latest clinical trials, to actually bring that to the room, bring that into the decision making. I think that will make a big difference. Is
there a generational difference in terms of like the acceptance of things like AI for an MDT, or even even Teams or Zoom for an MDT? Do some of the older consultants, older oncologists, do they like to actually do more face-to-face? Are the younger ones maybe more able to, or more willing to go virtual? Yeah,
I don't know which group I fall into now. I do ask my children to can you turn on the telly? I can't work it out.
Because I'm in my 40s now, and
yeah, me too.
I like doing these podcasts in person, because I like to look at people and talk to people, and I find you get a better level of discussion. I wonder if it's the same, or if some people feel it's the same with MDTs.
Yeah, I think most people do value human contact and human interaction to help, when making decisions. I guess it's similar perhaps with consultations with patients. Some patients are happy to speak on the phone.
Yeah.
Others get a lot of value from meeting in person. I don't know if there's a generational difference.
Don't want to offend the older folks.
Yeah,
we were all forced into it during COVID, weren't we? So there was no option but to.
That's been a benefit, though, hasn't it?
Yeah, I think so.
I think
would you not have
done that without COVID?
And a lot, a lot of grandparents Skype their grandkids or FaceTime them, whatever.
My mum can't figure it out. Yeah. No. No, but I think that's interesting. Would we have got to, would we still be doing initial appointments face to face, without COVID? I don't know.
I think there's been a big push back to trying to do more face to face in the NHS generally. I think there is value in it still.
I think so. I think a good old face to face contact. You get the emotion, don't you? You get the nuance when you're talking to someone face to face that you don't get virtually. Well, listen, that's been really, really, really interesting. I think it's something that probably every single cancer patient will have heard the term MDT. Probably 8 out of 10 will never have had it properly explained to them what goes on, who's in there, whys and wherefores of that meeting. So, yeah, do appreciate it. I found it, really interesting. I think that probably the image that I had in my head of an MDT probably isn't exactly how it was, but yeah.
I wonder if it's worth mentioning. So Ben, I don't know if you did the costings around how much money resource there is in kind of one meeting, and sort of MDT meetings cost annually, but it's a phenomenal amount. And so I think that's why, this work that we're doing around streamlining is really important, because if we can use that expertise and that huge financial resource for those really complex cases that will really benefit from it, and streamline out the more sort of straightforward protocolised ones, I think that's going to be a huge resource saving to the NHS. Do you remember any of the numbers?
It's hundreds of millions.
Where does the cost come from? What's the
paying
time?
Paying people to be in the room. Yeah. If you've got 30 healthcare professionals in the room for 3 hours, that's a lot of people's working weeks when they could be perhaps doing other. If we could do things more efficiently, they could be doing other things.
Does it always need 30? Could it be 5?
Yeah, not always.
Interesting stuff. I think it is fascinating. Like I said, you've definitely debunked a few myths in my head about what they look like and what happens in them. So thank you very much, Ellen and Ben. Thank you.
Thanks for having us.
Thank you.